Thank you very much. Thank you to the organizers for giving me this opportunity to represent the perspective from Tanzania. As previously introduced, I am Ahlam Nasser. I'm a consultant hematologist at the Muhimbili National Referral Hospital and a lecturer at Muhimbili University of Health and Allied Sciences. So the topic I've been asked to present today is when and how to look for BCR-ABL mutations, giving the perspective from Tanzania. So before getting started on the topic of today, hold up a minute. I think I'm having lag time on the slide progression.
It looks like maybe you've got the pointer on, Ahlam. Is that? Oh, there we go.
No, it can move right now.
Okay.
Yes. So apologies for that. So just as a snapshot of CML care in Tanzania, we have CML is like the most commonly diagnosed leukemia, comprising about 45% of all patients presenting with leukemia. We see about 50 to 80 patients per year. And as other African countries where they have presented, we do see younger population, 1 to 2 decades younger. Our median age is around 40 to 45 years, but other reports we have median age of up to 38 years. So we do have younger patients compared to other studies in Caucasian. We do have imatinib, which has been made available through Max Access Program since 2004. At the moment, we have 2 sites where the patient can get imatinib and other TKI. The Ocean World Cancer Institute, which is located in Dar es Salaam, and it has about 490 active patients. And Kilimanjaro Christian Medical Center, KSMC, which started to have access to imatinib from 2018, which is located northeast of Tanzania, and they have about 116 active patients. But as you can see from the map for the entire Tanzania, we only have 2 centers where there is access to TKI, and therefore patients have to travel all over Tanzania to these sites. So you can just imagine the cost implication associated with long distance travels. So how do patients really present? We have some evidence from our local research that we have done. Patients at diagnosis, they do tend to present with large disease burden. They present late. Jabuka et al. Had demonstrated that the mean duration of symptoms is at least 1 year, 15 months plus or minus 9 months, 1 year to 2 years before the patients present to the hospital. So by the time they have symptoms, the patient may stay at home trying different things, or maybe going to the peripheral hospital, but the diagnosis until by the time they are coming to be diagnosed, from the time they've started having symptoms, it has been a while. And therefore, we do see patients presenting 90% with splenomegaly, and 50 to 60% of those ones, they do have massive splenomegaly. By that, I mean that the spleen size is more than 20 centimeter below left costal margin. So you can just imagine the burden of the disease. And they do tend to develop and present severe anemia requiring blood transfusion. At least a quarter of the patients, they do present with very low HB necessitating transfusion. Hepatomegaly is also very common, and we do see very high white cell count at the time of diagnosis. Some patients, they go to as extreme as 800 white cells, and even though the patients are diagnosed in chronic phase, but they are in late chronic phase, and they are at a high risk group, whether SOCO or UTOS or ELTS, they fall under the high risk category. So during treatment, we also see high rates of cytopenias, and we believe this is largely contributed by high disease burden and diagnosis, such that the normal stem cell that is supposed to replenish the bone marrow after TKI initiation, they are no longer there, and then the patients do tend to have cytopenias. So because of cytopenias, it necessitates multiple drug interactions, and therefore it becomes a double-edged sword. Patient has not been very well exposed to imatinib, but because they develop cytopenia, you have to stop the TKI to allow recovery, but then that allows for the patient also, it puts the patient at risk of transformation. And this is what we have observed in our setting. So monitoring generally before 2019, ever since we started imatinib in 2004, was mainly hematological. And this is because the cost for PCR was very high. And this is because the PCR was done abroad. We did not have the capacity to do in country. And the cost by then, it was around $250 to $350. And therefore the patients were only monitored by using complete blood count. So in 2019, we had formulated a study that had recruited all patients that were on treatment and assessed their molecular response. Because of that study, we were able to showcase to the hospital that the patients, even though they only see 50 to 60 patients per year and may not be significant enough to make a case to ask for a new test, which is expensive, but if you include the monitoring, which is supposed to be done 3 monthly, then that is a large number of patients, and therefore this test is in demand. Following our study, we were able to convince the hospital, and we were able to lower the cost of PCR from $250 to $350 to $60 to $70. And this is largely thanks to the collaboration between Max Foundation and Cepheid that lowers the cost for the gene expert kits to half of the price for low middle income countries. So since 2019, we are able to do molecular monitoring. However, of course, we do not have the luxury of doing it every 3 months, and therefore we do encourage the patients to at least do PCR 12 monthly so that we know where they stand in terms of their response. So this was the results of the study that we've done. If you look at this plot, we have on the y-axis the BCR-ABL ratio for the patient, and each dot represents one patient. And on the x-axis, we have time since they've started treatment. And this highlights the point that Samuel has mentioned, that we do see patients on imatinib over years with no appropriate decline of the BCR-ABL. And this is largely contributed by the fact that they do present with high disease burden from diagnosis. And therefore, even though for this study we were a bit ambitious, we were looking for a major molecular response. However, when we did reanalysis to compare at least those who had a complete cytogenetic response, the results were not different. Only 24% of the patient, as you can see below this line, were the ones that had appropriate molecular response according to the time they have been on imatinib. So a large chunk of our patients do not have a good response. And based on these findings, we were able to have a conversation with Max Foundation, and we are able to secure other second generation and third generation TKIs. So going to the topic of today, when and how to look for BCR-ABL kinase mutation. With regards to when, this has been beautifully put forward by the ELN 2023 laboratory recommendations. Whenever you have a patient who have failed, who has fallen into the category of failure or warning during their treatment, then these are candidates who are eligible for mutation screening. Any patient who has progressed on TKI, that's also a candidate for mutation screening. And of course, for those patients who have been diagnosed at advanced stage, accelerated or blast crisis. Those are also candidates for mutation screening. Other group of candidates which we do not see in our setting because we do not do transplant is those patients who have relapsed and they have PCR above 0.1%. As with regards to how, that's a very good question. Over the years, Sanger sequencing has been a gold standard. However, the limitation of which has been sensitivity of 20%, meaning that you're able to detect mutant allele when the variant allele frequency is more than 20%. As of recent years, a couple of years, NGS has also been recommended and approved to be used for mutation screening with better sensitivity of about 3%. Therefore, it allows early detection of clinically relevant mutations. So that is generally what is recommended, but I wanted to highlight of what we actually do in our setting and comparing to what is recommended. So first of all, in a clinical setting, BCR-ABL mutation analysis is not routinely available or affordable. So the test is done abroad, India, Mumbai, and the cost is around, and even South Africa, and the cost is around $260 to $300. So you can imagine this is a lot of money, and not many Tanzanians are able to afford this. However, it is available in a research settings in a study that we are currently conducting. And the eligibility criteria for those adult patients, and this is because the study wanted a homogeneous population of adult CML, and the inclusion to get the mutation screening is a patient who has shown signs of TKI resistance, defined as falling in the failure category at any treatment milestone, whether the patient has not achieved complete hematologic response at 3 months, or having BCR ABL level of more than 10% at 6 months, or at any time from 12 months and above of more than 1%, or if the patient has progressed and has lost complete hematologic response. So which platform do we use? We actually use NGS, Oxford Nanopore sequencer, and for various reasons. The first and the foremost, or the most important, it was because it was available. So availability from other previous studies that were conducting molecular studies in other hematological malignancies, through the collaboration between Muhimbili University and University of Oxford in UK, but also because of its sensitivity and the ease of the procedure, one PCR step. I'm going to highlight that in the next slide, but of importance also affordability and sustainability in terms of it's a small equipment with no much cost associated with maintenance. And we were hoping that if we are going to roll out in the future to other centers, it might be easier because it's very portable and it can, as previously mentioned, does not require much maintenance. So this is the summary of the procedure that we are currently performing for the BCR-ABL mutation. The blood we collect through EDTA tubes or Paxton tube, depending on expected time of extraction of the RNA. RNA is very unstable and it's a headache dealing with it. The sample that we use, it's peripheral blood or bone marrow, depending on the white cell count. If the white cell count is low, below normal, then the option is bone marrow. However, that is also another challenge, as not many patients are also able to pay bone marrow. So for the study, we mostly use the peripheral blood, and from the peripheral blood, we do RNA extraction using QIAGEN kits, and we convert the extracted RNA to cDNA. After that, we do multiplex PCR to amplify the BCR-ABL fragment, which is about 1.56 kb. So it is a significantly large fragment. After that, we do library preparation and barcoding, and we load onto the flow cell of the nanopore for sequencing, and we have developed our in-house bioinformatics pipeline for variant calling. So the region that we're screening is as per recommended. So basically with nanopore, one of its advantages is that you only need one PCR, meaning that you're amplifying the BCR to ABL portion. Whereas for other method, you'll need after BCR to ABL, you also have to amplify the ABL kinase domain. So with nanopore, it has capacity of taking in large fragments and sequencing large fragments without having to fragment the protein. And therefore, we do sequence the entire fragment. And this is the region that we are actually looking for, the mutation, which actually spans from exon 2 to exon 10 of the ABL kinase domain. So what does it take to set up a mutation testing lab? This is the question I was asked to discuss. I've tried as much as possible to be comprehensive, but also to summarize. As expected, financial resources are a big chunk of what is needed to set a mutation lab. You'll have to have equipment, a laboratory space, adequate laboratory space, as some of this procedure, PCR need to be separated. So you need adequate laboratory space, consumables as well. And with regards to consumable, as we know, majority of these consumables you have to import from either US, UK, so cost implications related to purchasing and getting the consumables. Also of importance is human resource. You need a resilient team who is willing and motivated to build something from scratch. Remember, a lot of these tests are not or were not previously done in country, and therefore, even in terms of training, this is not something that is particularly the training of which is particularly given. So the research staff or the laboratory scientists have to be willing in terms of learning new techniques in work, and majority of them they do develop through working on the project. And the task, the human resource also should be able and willing to be multitasking. When working in developing countries, we do not have the luxury of just focusing on the research component. We find ourselves getting involved with authority, regulatory bodies to make sure you have the consumables, to make sure you make the case of why this consumable should enter the country, getting the suppliers. It's really, really, really difficult and a big headache. But of importance is also having collaborators with similar vision and passion. Those collaborators who see the future where you are actually building the capacity in country instead of doing helicopter science. It's very easy to transport the samples outside the country, and it's easier that way. You can quickly get the results for the study. However, at the end of the day, it does not contribute to building capacity in country. So having collaborators who share similar vision and willing to do mentorship and also knowledge transfer is very important. Additionally, having institutional support, government support, buy-in of stakeholders, but most importantly, the patients or advocacy group of the patients, so that they understand what is the new test that the research is working on and what are the importance of the results, so that they can also help to push with the government and take up of the test. And while developing a research or a mutation testing lab, starting as a research, you should always have a sustainability plan in mind. What could be feasible and affordable on the long run? Regarding challenges, these do overlap with what I've mentioned regarding what is needed: infrastructure, accreditation, procurement system, you find a lot of these are not in place, and therefore it's a hassle to build everything from scratch, to push in for supplies and the reagents. But also with regards to financial resources, sometimes you do see, you do get unforeseen expenses, price inflation. So as part of the policy of the country, for any, unless if it's for purely research, but if it's for commercial use, reagent or consumables, they have to have representative who has registered that product with the government. So whenever you have these middle people, what we find is the price, there is so much price inflation for the consumables, it becomes a very difficult to sustain. But of importance is time. The delivery for consumables is very long. Just a simple primer, you can take up to 6 weeks. So you can imagine if you have research that you are performing, you rather just put the samples on airplane and send them somewhere else to collaborator to do that. So it makes it very difficult and lag times because you do not have the luxury of getting the quick assistance or quick deliveries that you will have preferred. Sample logistic is another challenge that we face. And this is why, for starters, for the mutation screening, we have limited it to 2 institutions in Dar es Salaam, Muhimbili and Ocean Board. This is because RNA is very unstable, especially in a condition like in Tanzania, where there's humid, high temperature. And for other studies where we tried to transport samples from up north of Tanzania, we were not able to get good quality RNA. So long distance sample transportation without degradation is also a challenge. I think Samuel has highlighted this, even for diagnostic samples that have to be shipped outside the country. And another of importance, maybe this can also bring into the discussion, is variant interpretation and validation. We know there's inadequate representation of African population in genetic databases, and therefore sometimes it is difficult to interpret the variant that you have obtained, whether they're pathogenic or not pathogenic. I'm not sure whether I should continue with the presentation, Amanda, or would you like to have a discussion and then I proceed?
I was just thinking, these were fantastic slides on not just for setting up a mutation lab, but I think for any healthcare innovation or improvement piece of work that anyone was doing. What a fantastic overview of the challenges and the enablers that you need in place. It would be great to get to the discussion, but if you want to just quickly, maybe 2 minutes, just finish up. I know you had some cases and present the questions particularly that you're interested in, and then we'll bring Katerina and Samuel back in and others on those questions.
Excellent. So let me just wrap it up. So I've been asked to talk about what could be an alternative option if your center cannot set a mutation lab. I think this is an interesting and important question, and I honestly do not have an answer to it. However, I will share what is the vision of our team. So we have recognized this as an issue in terms of, with research, how do you integrate what you have built from research into service so that to help patients, how does it translate from the bench work to actually having it integrated into the service, especially for diseases where it may not be considered as a big niche, like what Samuel has highlighted, like CML. This is a hematological condition, might not be as common or as of public importance or priority compared to other conditions, infectious diseases like malaria. So this is what we had in mind we had established a spin-out from the university, which is called Cyanox Africa, the aim of which is to stand as a lab where it can offer molecular testing, not only for Tanzania, but other African countries. So at the moment, we are in the process of accreditation, and the hope is Cyanox Africa in the near future will be able to absorb all the human capacity that we have created through research, but also the technical how that we have built over the years. So using Cyanox Africa as a model, having collaboration between African countries such that we have few selected centers with capacity and appropriate accreditation to do mutation screening will be very important. It will allow pooled samples and subsequently lowering the cost, because it is very costly just to run 1 to 2 samples per week with flow cells, which has the capacity of running at least 30 samples, and therefore eventually we'll be able to reduce the TAT as well. So I have one last slide, bringing back the discussion to a patient. I think this is very important, and this is the reason of why we're doing all of this, to improve the patient care, not only in our setting, but in Africa overall. So we had a 26-year-old male patient who presented with symptoms of anemia, B symptoms, abdominal distension for 6 months. This was back in 2021. On examination, had splenomegaly of 18 centimeter below left costal margin. White blood cell was around 260 and basophilia of 3%, and had hemoglobin of 8.4 and had thrombocytopenia. Bone marrow revealed blast percent of 5%, and therefore the patient was termed to be in chronic phase. And the PCR done was at 120%. SOCO score scored the patient as intermediate risk. UTOS and ALTS risk scored the patient as high. So the patient was referred to Ocean Ward for TKI and was started on imatinib. As you can see, by 3 months of imatinib, the patient did not achieve complete hematologic response. Instead, the platelet had shoot up. Of course, he was no longer thrombocytopenic, but had thrombocytosis and had significant elevation in white cell. The patient was still had a blast count less than 10% and was still in chronic phase. Following this finding, it was decided to switch the patient to dasatinib. However, since dasatinib is not immediately available, patient was placed on hydroxyurea for 1 month while waiting to switch to dasatinib at 100 milligram once a day. Following dasatinib initiation, 1 month, the white cell had reduced. Actually, the white cell had reduced because of hydroxyurea. At 1 month, still the patient had high white cell. However, the anemia had improved, but thrombocytosis was getting worse. But luckily, at 3 months, the patient had attained complete hematologic response. And the patient was doing well until when he came back. So they are seen after every 3 months, because majority of patients are coming back from very far away. By the time he came for 12 months checkup, he had already lost hematologic response and had thrombocytosis of 1,000. So by this time, this is when we had taken blood for mutation screening. However, by then we just started, and the information that we had received, it did not help much to the patient because we were having challenges in setting. Nevertheless, because patient had been already on 2 TKIs, it was the best way forward. It was to place the patient on ponatinib, because that's an indication after failing 2 TKIs, and therefore the patient was placed on ponatinib. Unfortunately, the response was also not good on ponatinib, and the patient continued to have elevated white cell, and the patient had passed away after 3 months of being on ponatinib. When we got the mutation analysis results, the patient had compound mutation at different regions. At the P loop, arginine at position of 239 replaced by histidine. Another missense mutation at position 222, valine for isoleucine, and at position 460, arginine to histidine. So maybe the question to stimulate discussion is, yeah, maybe a quick comment on this one. So when we look up, these mutations have not been reported in terms of in CML and causing resistance in CML. However, they have been reported in other malignancies, including stomach and melanoma. So questions for discussion maybe for our expert is how really do you interpret variants that have not been previously reported? How to differentiate between bystander from pathogenic variants? And for bringing back to the patient, which could have been the best TKI for compound mutation and what could have been done differently. Apart from bone marrow transplant, which we know as an option, but in our setting, that is not really an available option. Was there anything else that we could have given this patient? And while second generation or third generation TKI are not immediately available, in our case, we had at least 1 month, we had to wait at least for 1 month. How long after the patient loses complete hematological response before they actually transform to blast crisis? Otherwise, I would like to acknowledge the efforts of everyone, including mentors, collaborators, but all local teams, hematologists. The work that I've presented is not myself only, but it is accumulation of work of many people, many individuals who share similar vision of improving the care of a CML patient in Tanzania. And of most important is the advocacy group, the Blood Cancer Foundation of Tanzania, for the continuous support in giving education to the patients. Thank you so much. Back to you, Amanda.
Thank you, Ahlam. Yeah, great if you could leave your question slide up. Thank you and also to Samuel for so generously sharing what you are doing in your setting with us and offering that for our discussion. And I wonder if I can encourage others who are on the call. We're here to learn together and share our knowledge of what is working. So if you are doing something else or you're doing something similar, it would be great to hear about that. Please offer what you're doing in the chat, and there are some questions also that we'll come to, but I'm just wondering first if Katerina, Samuel, if you'd like to jump in and respond to Ahlam's presentation and her questions.
Yeah, thank you very much, Ahlam, for beautiful presentation and overview. And I think that also Samuel has had some question regarding mutation analysis. I understand or I understood that in your countries, this is quite difficult to perform mutational analysis in all hospitals or centers. Am I right?
Yeah, correct.
Yeah. Do you think that it can be feasible for you to centralize this type of analysis? Because I think that the number of patients that require mutation analysis may not be as high as for a real-time PCR. So do you think about the idea to centralize the mutational analysis in your countries?
Absolutely true. Absolutely
Yeah.
true. The senior hematologists are in the central facility.
Right. I think this is a great way. And you touched the question, the instability of RNA, and also you touched the question how to learn a local laboratory to do some analysis. So I think regarding on the possibilities in each laboratory, the simple way may be to learn how to isolate leukocytes, isolate RNA, and to perform reverse transcription, and then getting cDNA. cDNA is more stable for transportation to centralized laboratory. I think this may be the possible way avoiding RNA degradation during transportation, because during transportations anything can happen, right?
Yeah.
Absolutely true.
Right, great. And if you want, we can go through the question that Ahlam nicely raised. Are you okay with that?
Yeah, absolutely. Well, we have a few other
regarding
questions. We have a few
okay,
questions
so
too,
yeah,
but
it's up to you,
but
Amanda.
I think let's you know, I think why don't you take your top two and we'll see how we're doing for time.
Right,
and
great.
if that's okay.
It's up to you, Amanda.
No, yeah, no, please do. I'm not gonna guide you in that. I think if there's a one that you particularly want to get stuck into, then let's go with that one first.
Okay, so just I can go through the Ahlam, because of the time, tell me the burning question from those questions. We can discuss a little bit quickly.
Yeah, so I think the most important one is especially for bringing into the context of the case, having those mutations that have not been previously reported
Right. Yeah.
in the ABL, but the patient definitely does have resistance. How do you interpret that in the context of whether the variants that you have isolated are pathogenic or not?
Right. I saw in this case these three BCR mutations that are really like unknown, or we don't know. We didn't see any reports that mentioned these type of mutation to be pathogenic. So do you know what is important is variant allele frequency? Do you know the level of these of the compound mutations in the sample or analyze? Because
Yeah,
this is important.
Yeah,
remember?
I think that is a very good question. I don't remember the numbers at the top of my head, but they're definitely around 20 to 30%.
20 to 30%. Okay.
Yeah.
And so with the nanopore technology, you're working with cDNA, so you definitely sequence the amplicon from BCR-ABL. Am I right?
Yes.
Yeah.
Yes.
So it's quite a high percentage of this unknown mutation, and it's really difficult to say what to do with knowing any with having any idea about the sensitivity to TKIs. So it's what the other question is quite related to this. This is really
whether it's bystander or whether
bystander,
it's pathogenic.
yeah, but pathogenic, 20-30%. Yeah. I think that the most potent TKI to compound mutations is ponatinib, right? But you saw, you showed in this case that ponatinib was not helpful. And the patient died CML. This was the CML related death, right?
Yes.
Yeah.
Yes. CML related death, transformation. So at 3 months of ponatinib, the white cells did not go down, and then the patient had succumbed to death.
What we would do in our lab, I'll tell you, once we have such results with unknown mutations, with high percentage of the mutation, and we would perform the in vitro analysis with TKI, so putting the cells for 24 or 48 hours, keeping them with the TKI. I would start with ponatinib, of course, and we would measure IC50 to see. But of course, then we need to wait a little bit, and we don't know if the patient has time to wait for the result. Also, we would perform analysis to avoid whether these mutations are germline mutations, right? Of course, but probably not, because you performed the analysis from the BCR-able region. So it's it may have relevance to resistance, but so far I really do not have the clue what to do with this case and with this unknown mutation. So as I mentioned, we would perform in vitro tests, right?
Okay.
Yeah. What?
Is that helpful, Ahlam, or reassuring in any way?
Yeah, so it is very difficult, and we do realize that, and that is one of the option. However, might not be easily accessible.
Yeah.
And therefore, correlating with clinical results also, they have to be interpreted in terms of the clinical context. And it's not always that we get mutations that have not been reported. Sometimes the case is straightforward. You have mutations like 315, which has previously been reported, and it's quite clear. However, in sometimes these are the challenges that we face, and I thought having such a case, it would be very beneficial to discuss.
Yeah, absolutely. I wonder, Samuel, have you experienced a case like this? Is this something that has come up in your practice? You're on mute.
Yeah. I can't, because of the interest of time, I couldn't present it all the sequencing, but using the Sanger sequencing, I came across one unique mutation, which I don't exactly remember in my mind, but it was not able to find it in somewhere else. So we just simply keep it, because we thought that we have to repeat the sample, but we have still the left of sample that the mutation was really happening, but we have the same thing.
Yeah, thank you, Samuel. I wonder, Ahlam, if you could just put the slide back onto your questions. We are coming to the end of our time that we have here together, but I think this is a really interesting topic, and I know a lot of people were keen to have this discussion. So if there are, if any of those questions are particularly ones that you would like to have more discussion on or hear more about, please note them down and put them in the chat, and then when we look at the recording later, we can pick those up and respond to those. So almost like voting for your favorites, if there are other questions also that you still want to add. I just want to, before we close, go through some of the questions that were in the chat. I think most of them have actually been answered already. There was a question for Samuel about the analysis, which you have answered in the chat, and if any particular software was required, which you have said that it wasn't, and pointed them to your paper in Annals of Hematology. Also a question around what was available at Ahlam's institution, and it looks like you've made a connection there, so I hope that's going to be really useful for Ahlam and Augustine. They're just making sure that we've picked all of these things up, and also question around compliance and knowledge of mutations, which Ahlam, I see you've just answered in the chat as well, that compliance was good, but screening wasn't. I guess, was it not able to be done at diagnosis? It wasn't indicated, or it's just not your practice? Yeah.
So generally, with mutation is not indicated diagnosis if the patient is in chronic phase, so that was not done.
Yeah, that's fantastic. And I think that is all of them. There was just one question around, you'd mentioned late diagnosis, and a question about what you think might be driving that and people's awareness, and whether that's being, whether symptoms are mistaken for other diseases that are more prevalent. So just another question in there. I don't think we have time to respond to that right now, but but if you want to drop something in the chat, or we'll note it for next time around different presentations and late diagnosis. I'll just stop a moment. Any last thoughts from our panel, or indeed from any of our audience who want to just comment as we bring our discussion to a close?
Well, Amanda, if I may, I think that your suggestion is great. That because Ahlam and Samuel, they raised great questions, and other in the audience, and we can do that. That we can answer to them and put them on demand. Or yeah, this is great idea actually.
Yeah, I think that would be super. And I know that most of you will have received your joining instructions from my colleague Arlene and have her contact details. Please get in touch and with your questions, and we'll look at some way of collating those and reflecting on them more and feeding that back. And great to have everyone's enthusiasm for doing that. We've come to the end of our time. It's been so lovely to have you here. Thank you once again, Katerina, Samuel, Ahlam. Really interesting discussion. Lots of points to reflect on, and so many different issues. We really hope to be able to see you online, all of you, between these discussions. Please check out the ICMLF Knowledge Centre online. On the website, there are papers of the month, clinical discussions, different programs and activities happening. The foundation is also active on social media, Facebook, Instagram, and X. If you use those, we'd love to have conversations with you there as well. This is our final Africa regional discussion for 2024. It's been great to be doing these with you the last few months, and I really hope that we will see you again next year. Until then, please keep in touch and have a lovely winter, and we'll see you in the new year. Thank you very much, everybody.
Thank you very much.
Goodbye.
Thank you.
Bye.